Dr. Carlson is at the University of Kansas. For those of you who don't know him, Nick, I see you're on, and a few other folks are attending that are outside the fellowship. Brandon came out for a week, Brandon, and spent some time with us, just learn a little more about MIS and lateral. And he's extremely well trained and an excellent deformity surgeon and degenerative surgeon, and has gone back to Kansas and is showing Doug Burton some things, right, Brandon?
I don't know about that, but it's good to have some different perspectives to bring to the table.
Yeah, exactly. Broaden your vision a little bit. So anyway, Brandon's kind enough to give us a short talk today on metabolic bone disease, something that we all have to be paying a lot of attention to. So thanks for spending some time with us this morning, and we'll get you started so you can get to your case.
Yeah, appreciate it. Thanks for the intro there, Bob. And as he said, I'm at University of Kansas. Mark Asher is the namesake of our spine center, and he knows Dr. Agbarnia very well. Unfortunately, passed a few years ago, but been fortunate to come back to a program that has a lot to offer and is growing. And as he said, my senior partner, Doug Burton, certainly has a tremendous amount of experience, but it's fun too to bring back things that I learned elsewhere and sort of add ideas to the table. And it makes our spine conferences interesting. But anyway, this talk came up. I was at a conference actually with Mundus, and I got all upset after a discussion about metabolic bone disease. And there was some numbers thrown around in one of these talks, and I just was like infuriated that people don't get it, or they don't understand the different ways that it's diagnosed and which numbers we should look at. And so he suggested that I maybe put something together and hopefully clarify some of that. And hopefully that'll give you a little bit of something to take away. And I'll kind of highlight the slide that I think is the most important for that here in a minute. But I do have disclosures. None of them are relevant to this talk, but I received some consulting and research support. So why is this a problem? I mean, we see this all the time now, and especially the fellows, as you've gone through, this is part of our daily routine with spine patient evaluation now. 200 million people over the world now have osteoporosis or metabolic bone disease. And that actually number is probably dated from 2007. It's probably much higher than that now. But back in 2010 census data, we had about 10% of the population in the US had osteoporosis, and over 40% had low bone mass. So it's a real problem. And really, I think that one thing that spine surgeons don't quite pick up on or always know is the definition. So osteoporosis is really it's a disease of living bone that results in skeletal fragility in which bone, both density and quality are low enough that low energy can cause fractures. So that's the thing that people quite don't understand is, they think of osteoporosis and then they just think, oh, they have weak bones. But what it is it's a risk factor, or it's a disease category that says that you have a risk factor for fracture with minimal trauma. So how do we get there? Well, we're surgeons. We love images. We love imaging studies. And so I'll just kind of highlight the mainstay categories of how we get our diagnosis or our diagnostic categories. So Dexa is the number one. It's the gold standard. It's been around since the 60s. We can measure from the spine, wrist, and hip areas. And we get a measurement that's in bone mineral density, and then that's converted to a T-score. And a T-score is what we're all very, very familiar with. So I'm not going to belabor that. T-scores then have categories, and I'll get to those later, that would then put people in normal, osteopenic, or osteoporotic. There are advantages here. They have low radiation. You can repeat it. You can trend bone mineral density over time. The most research on bone mineral density as well as osteoporosis is on Dexa or follows Dexa, but it is less specific for cortical or trabecular bone. And we know that degenerative changes, especially in the lumbar spine, will overestimate this and might give you a false reading. CT has also been suggested. This is actually a measurement of Houndfield units. And so I'm already getting into the premise of why I was so upset during that conference. So Houndfield units is just a measurement of attenuation. So it's actually just looking at the density of the picture, and it converts that to a number for you. And so it's not actually a measurement of bone density. So bone quality and bone density can affect the attenuation level. There have been correlation studies that show that Houndfield units do potentially correlate with bone mineral density and Dexa. That might also be mostly in the femur, but less so the spine. But there are good studies that show that there is some correlation between the spine as well.
The reason we like it, it's quick and easy. We oftentimes get CTs for pre-op planning, so it's opportunistic. You can pull a Houndfield unit straight off a CT that you got just for surgical planning or screw planning, and you'll have a number that you can at least look at and reference. It is accurate in degenerative changes. You see those regions of interest on the right side. They show that you can exclude the degenerative conditions or the degenerative features, and that way you get an accurate reading. It does require a CT scan, which has radiation. It might be more cost if you were getting a CT just to measure this. But again, it doesn't measure the bone mineral density. So, clinicians really need to understand that it's more of a measurement of the picture attenuation. And so these thresholds that are thrown around based on Houndfield units, they're useful and it's a good tool for surgeons, but it's not a perfect correlation. It's not a true diagnostic category. And the big thing is that surgeons, especially, I think, confuse Houndfield units and QCT all the time. So what's QCT? It's a bone mineral density measurement, but it's quantified using a software. So it almost looks exactly the same on those pictures on the right. But what happens is it's referenced to a phantom, which is either placed under the patient, or there's now phantomless technology that uses the quality data from a CT scanner to convert that attenuation measurement to a bone mineral density, because it's been calibrated to a water phantom or something else that's a known density. This has actually been validated with the ACR, the American College of Radiology, and they've created diagnostic categories. So you can see that table there. Greater than 120 is actually a measurement of the hydroxyapatite in the bone, and then 80 to 120 would be osteopenic, and osteoporosis is less than 80. I'll get to these numbers again here in a minute to talk to you, kind of the punchline of the paper or punchline of the talk, so that maybe you take away something in terms of QCT versus Houndfield units versus Dexa. Once again, much more accurate. You can isolate just trabecular bone if that's what you're interested in. You can exclude degenerative conditions or degenerative changes or blastic areas inside the vertebral body. It does require radiation or a CT scan. It could be increased cost if you're ordering it separately. Some systems or some ways of obtaining this do require that the phantom be under the patient. So if that's something that's not in the standard workflow, you would have to ask for another CT for that. And it's also not widely available. You do need special software for this, and it is kind of expensive. So who are we supposed to screen? Females over 65 and males over 70 is the current WHO recommendations. But we all, as spine surgeons, kind of look at every patient and decide if we need to screen them or not. I think that some people even say over 50. Anybody that needs a spine fusion over 50. It's not a validated criteria based on WHO, but things like medication, smoking, alcoholism, history of fragility fractures, all of these things would turn our attention to the fact that we need to look at their bone density before we take them to surgery. And so really for this audience, the patients undergoing spine fusions are now a highly screened population, and it doesn't necessarily follow the WHO recommendations. It's oftentimes, what kind of surgery they need or how big is it, and that might direct whether we screen them or not. So then how does this all work? Dexa, obviously widely used. It can be turned into a FRAX score, which is a fracture risk assessment tool. Again, probably more relevant for the people that trend osteoporosis patients long-term. You're not necessarily going to take a FRAX score and turn it into a decision on your surgical tree, but it certainly is a number that is widely published now and trended. It's interesting though, the FRAX score does need the femoral neck DEXA. So we oftentimes get DEXAs at the wrist or in the femoral neck or in the spine, but the femoral neck is the one that's validated. It's WHO recommended, and it's the T-score you should follow. So when we get DEXA scans on our patients, they always get the spine and the femur. I don't even look at the spine anymore. The numbers are all over the board sometimes. Sometimes they're low, sometimes they're high. But the femoral neck is the most reliable one, and that's why it's used for the FRAX score. Again, it evaluates their future fracture risk. Quantitative CT, once again, it's a measurement of bone mineral density. The ACR criteria says to look at L1 and L2 and average them. You can use that to diagnose a patient as normal osteopenic or osteoporotic. And it is a volumetric assessment, so it does give you a better evaluation of that specific vertebra, that region. There are other studies that have been done. I was helping with one of them at HSS that looks at the entire spine and how well that correlates to that ACR L1 and L2. And there's a high concordance, except for the sacrum, of all the other segmental levels. L1 through L5, besides the sacrum. The sacrum seems to be a little bit different than the rest. Femoral neck BMD can also be measured using quantitative CT, and people do that, and that can be used in the FRAC score as well. So the Houndfield units, the most controversial of these, I think it does give you useful information. It measures attenuation, like I said before. It's not density. Correlates with Dexa, but there is a lot of controversy behind this. You can see this paper by Mike Kelly and his group at WashU that they tried to replicate something that was done in the degenerative spine population, and they didn't find that the lumbar computed tomography Houndfield units were a very good measurement of bone mineral density in deformity patients. So, again, not necessarily the gold standard, not necessarily a screening tool, but probably provides you good information regardless. And then there's several defined thresholds, and that's the tough part with that measurement, is that which one are we supposed to follow? So give me the numbers, right? That's what you guys wanted to probably see, or maybe not. But Dexa, we know the Dexa thresholds. Everybody should know those, and that's the easiest one. You order a Dexa, the patient comes back to your clinic, you should know the numbers and immediately be able to tell if they're in the normal osteopenic or osteoporotic. Whether or not you treat osteopenia, depending on what you're going to do for that patient, is kind of up to you. I think clearly osteoporosis needs to be treated before any sort of invasive spine surgery that would involve a fusion or interbodies or implants, et cetera. Quantitative CT, once again, those thresholds are defined by the ACR criteria, and they're listed there. Now, the CT is the weird one, the Houndfield units. There are thresholds all over the board. I mean, all the way to 203 down to 78.5. I've written in just kind of blurbs of what they mean. So like at 203, that threshold in this one paper found that that'll exclude every osteoporotic patient. Well, that's a pretty high threshold, right? Like I think most of my patients come in, they're not going to be in the 200s. They're going to be in the like 130s to 100s, hopefully. But you can see there's been a paper done on cage subsidence, and they found that a threshold of 135 was associated with higher cage subsidence. You got successful union at 133 versus non-union at 107. Those are from the same paper. And then really this 110 number seems to be thrown around a lot. It's a paper done by Wellington Sue and his group. I think that's the one I've heard most people talk about. And I'm not sure, Bob, what you guys are teaching the fellows, but 110 seems to be this number that I think is a good one. It's 90% specific for osteoporosis, and anything below that should be sort of investigated. There are other numbers. I think the 130 range or 135 is also, 139 for spine fracture risk is adjacent segment to a long fusion fracture risk. So, which number you want to pick, it's kind of tough. And then the second part of that is you got this number 110, and then you've got a different number with quantitative CT that's less than 80. And people are talking in the same conversation using both techniques, QCT versus CT. And some people get confused. They're not really thinking the same because one's Houndfield units attenuation and one of them is actually a measurement of hydroxyapatite. So that's frustrating, to say the least, that those numbers are so darn close. It'd be easier if there was a magnitude of 10 between the two and you could clearly know which one you're talking about. But that's something you need to be really, really careful with as you talk to people or you read papers, et cetera, on these types of topics, that you're using the right metric and you know which unit you're looking at. Also, the World Health Organization defined the Dexa criteria, ACR defined the quantitative CT, but these thresholds are coming from all sorts of publications, and they're all well-intentioned, don't get me wrong, but none of them have been decided as the consensus statement for the number you should pick. So just keep that in mind as you use this tool when you're evaluating your patients. Once again, they're all useful tools, but just know what they mean. Know which one you're going to incorporate with what's information. Obviously, the Houndfield unit can be useful because you're going to get a CT for pre-op planning maybe, and you could easily measure it. Some of these others, you have to send people for another test. But certainly the Dexa is still considered gold standard and widely used and available. You can also trend it long-term. So what about labs? So, you can't talk about osteoporosis without doing the other side of it. Osteoporosis labs, 25 hydroxy vitamin D is number one that most people check. Calcium and phosphate are commonly checked as well. And depending on the calcium level, you might check a PTH level for secondary osteoporosis. Creatinine, alkaline phosphatase, all of these are metrics that people continue to monitor to look for the sources of osteoporosis. And then TSH in certain conditions can be elevated or decreased. And thyroid studies would certainly give you a direction toward why someone might be osteoporotic. So what do we need to know as spine surgeons? First off, I think that if you have any question that a patient has increased or decreased bone density, or you're concerned about that, you'd be really careful booking them for surgery right away. you need to understand why they have this disease. If you identify that they do have it, is it age-related osteoporosis, which is the most common? And at that point, maybe their primary care or an endocrinologist, if that's your comfort level, or yourself, you could treat this. It depends on what, where they are. If they're osteopenic or mildly osteopenic, or if they're very osteoporotic, you might change your decision tree based on that. And I think that's a preference by the clinician. Other reasons or other conditions, certain metabolic or endocrine diseases that cause osteoporosis, or even underlying chronic steroid use and things like that. I typically get endocrine involved, at least at some level, and just ask for their input. Some of these need to be watched and monitored closely. You can't just start them on with some of these medications without close monitoring of their response to them. The other thing you got to look at is, well, what do these people need? Is this a small degen procedure that you're going to do MIS and it's one level, or is this a massive deformity? Is it a cervical case? How urgent is the case? Is this something you can pre-treat them? And then what can you do, or what can you offer them based on what the reason is for their disease? And so there's a lot going into this. Spine surgery continues to expand, and there's patients that are growing older and older, and osteoporosis is certainly becoming much, much more prevalent in our population, and patients are demanding spine surgery regardless. And, their bones aren't getting any better, they're getting worse. And so we're trying to have to figure out, what are we going to do to these people before, so we can safely get them through a spine surgery. And so you'll see that there's, sorry, my arrows got off there. I'm not sure why, but you'll see that there's a lot of data out there. So the biggest thing I think that we use as our armamentarium up front before surgery is medications. The bisphosphonates, I think, are questionable, to say the least. There's been several studies on different bisphosphonates in terms of fusion rates. The one study of 2011 said that increased fusion rates. There's been a study that conflicted to that, said it decreased fusion rates. And then there's been some others that said there's no difference in fusion rates, but maybe the pedicle screws do loosen over time. So, I would say that if you're a spine surgeon looking to do a deformity surgery on somebody, you're not going to be giving them bisphosphonates preoperatively. And I think that you're going to start looking more at these anabolic agents. So we know about these. Forteo and Tymlos are probably the most prominently known and widely used at this point. This is sort of a synopsis table of the preclinical data on teriparatide, which is Forteo, and it showed that every single animal study showed increased fusion rates using this medication. So it clearly is a benefit. And so we've started using it in patients. We have clinical studies too. And Otori did 2 studies, and then Inu, I think that's how you say his name, in 2014 did another study. And these are the earliest of the studies, and there's been others that are in process or have been published more recently. But interestingly, it's all positive, right? So the fusion rate went up, the screw loosening went down, and the insertional torque went up. So we started using these, and we know that they're widely used now across spine surgery. And again, I think that there's not a consensus statement about whether you should or shouldn't use it, how you use it, and which patient population you use it. But certainly deformity surgery, it's getting used extremely commonly. We think that using medication and premedicating beforehand and after surgery gives us optimal results for both fusion, screw, and instrumentation, pull-out and problems, et cetera. The other things you can think about with your osteoporotic patients, if you take them to surgery, is things you can do in surgery. So the medications, again, are paramount for pre-treatment and preoperative evaluation and prepping these people to have a successful outcome. But during surgery, you can do several things too. Cement augmentation is a big one. We know it increases screw pull-out strength, that it decreases screw loosening. And the theory is if you decrease screw loosening, and that segmental fixation can hold in the timeline that needs to be maintained for a fusion to happen, then it'll increase fusion rates. So there's several studies on this. I didn't put the synopsis in because there's been lots of papers on just cement augmenting screws and getting better fusion rates. And I think in low bone density or low bone quality, it may or may not be something you think about using. It also may not impact future fracture risk. So if you cement augment a certain vertebral body, it's going to stiffen that segment, and the segment above, if it's not instrumented or not part of a fusion or doesn't have a lot of degenerative changes that can protect it, it might actually be an increased risk for fracture due to the load transfer. PJK prevention, these patients, we all know that osteoporosis or bone metabolism is a big factor in PJK. We know PJK is an anomalous, tough topic that none of us have figured out. We try all sorts of tactics and techniques. And so, in these patients that have worse bone quality, certainly there's more data now being supportive of age-adjusted alignment goals. And so try not to overcorrect these patients, might protect them from a acute fracture or failure. Tethering plus minus, I know there's data supporting it and data against it. I think that's a lot about how you train, maybe how you do your surgeries, where your UIV is, et cetera. There's some people that do advocate, my partner's a big one of this, of vertebroplasties at the UIV and UIV plus 1 or 2. This could be done at the time of surgery or after surgery. But again, it may load transfer and you might just see failure proximal to this. So I would tell you to use that with caution. And then the cement augmentation, maybe getting pull-out strength of your screws at the top of your construct, once again, could be used. Bone morphogenic protein in patients with metabolic bone disease, they're certainly at higher risk for non-union and they might not form bone as well. So BMP certainly is a product that is synthetic and has a high propensity for growing bone. I think if you're doing an open posterior fusion, I just, full disclosure, it's an off-label use. I think everyone knows that in this talk, but I think I need to just say that. But it will increase fusion rates. And in my personal practice, if I have a patient with metabolic bone disease, even with pre-treatment with Tymlos or Forteo, I do use BMP for that. If you're doing anterior-only surgery, it is an on-label use, and I think it certainly could be considered in that situation as well. Cage subsidence is a big problem for patients with bone metabolism or weak bones. I think that the larger the footprint of the implants, and I learned this, with my training and my fellowship, seeing it again with Dr. Eastlack and Dr. Mundus there, it's large footprint implants have a less propensity to subside, but there's also things you need to consider. What type of implant you're going to use, whether it's PEEK or bone versus titanium, that might affect how much you may or may not get subsidence. I really do not overstuff these patients. If you try to put in a really large implant and it's putting a lot of strain on that implant, it's probably gonna have a higher risk for subsidence. Percutaneous fusion and interbody fusion, it's interesting. Sorry, percutaneous fixation. This is how I treat a lot of patients with metabolic bone problems, weak bones, osteopenia, and I don't necessarily pre-treat every one of them. Now, if it's a big deformity, they all get pre-treated. But it's interesting with a wide footprint lateral cage or an A-lift that sits way out on the apophyseal ring, I haven't seen a tremendous amount of subsidence. And it's a topic I've tried to engage a couple people, and I might talk to Bob and Greg about is, with perc screws, you don't really disrupt everything in the posterior tension band. And we all know that topic. And I think that probably lends itself to maybe a little more support. And, if you do percutaneous fixation with large screws or long screws and you have a big implant up front, I think you could probably achieve fusion with a low failure rate, even in patients with poor bone. But I think that's obviously something that needs to be further researched before I can say that with confidence. Post-op care, my patients, if I put them on an anabolic agent, they stay on it. And I stay on it for about 3 to 6 months. Sometimes at 6 months, I'll repeat their Dexa of their femoral neck. And if they're maintaining or if they've improved, and many of them do, then I would consider talking to an endocrinologist about switching them to Prolia or denosumab. It's a once every 6 month injection, and it would help them maintain what they built up with their anabolic agent for a year, right? So 6 months before surgery, 6 months after would be a year. You only get about 2 years on the FDA approval, and there are people going off of that. There are people going up to 3 and 4 and 5 years now, and we're probably going to see some information about that at some point in the near future. I'm not involved in any of those studies, and I currently won't do it for my patients. I just don't know that I support it just yet, but I try to save an additional year if possible. So if I do 6 months before and 6 months after, I'll put them on something to maintain, whether it's a bisphosphonate or denosumab, I prefer. Then I can hold off on that second year, and heaven forbid that deformity patient needs another deformity surgery in a couple of years, and they might need to be pre-treated again. I can use that in the future. Proper nutrition is critical. I think that's an underestimated or under discussed topic. Nutritional status is massive for these patients, and we know about frailty scores and whatnot. But vitamin C, interestingly, is Dr. Asher turned me onto this years and years and years ago. It's a cofactor for bone growth, and so these patients a lot of them are probably vitamin C deficient. So all my patients that go on any sort of metabolic bone treatment, they go on vitamin C as well. Vitamin D and calcium are always included, but the vitamin C is something that a lot of people don't include. And then I recheck their Dexas annually, or I engage their primary care to do so, make sure that we're maintaining what we built back up. So that's kind of the gist of it. I think the biggest thing is, understanding which imaging modalities you may or may not use to screen your patients. I think we're screening at a higher rate because of the types of surgeries we're offering patients, because of their age and their conditions that evolve over time. Maybe they've had previous spine surgery, now they need a deformity surgery. And so as you use these different screening tools, you need to understand what they do for you and what to use over time. I show these pictures. I think it's funny when I always like it when people put pictures into their personal life after a talk. And so the top left is my OR team. And this is my partner here in the hat. He's my younger partner. We think a lot alike. He's the one that came out with you, Bob. That's Josh Bunch. And then that's our OR team. And the right is my wife. Obviously, we do a lot of this for family, and she's my most important piece to my life. And we don't have kids currently, but maybe in the future. And then I throw this out here as a welcome to anyone. So this is Allen Fieldhouse. I get season tickets every year. It's one of the best places to see a basketball game in the world. So anyone on this call, if you ever make it to Kansas City, I put my cell phone here and my email address. You're more than welcome to contact me. If it's around KU basketball season, I will take you to a game gladly and hopefully show you a decent time. So
go Chuck Jayhawk, huh?
There you go. There you go.
Well, hey, Brad, I want to thank you. I know you have to get to the OR. Great talk as usual. It's a very important topic to all of us. So I'm sure everybody on has enjoyed it and learned a little bit through the topic that you've obviously dug into.
Yeah.
And just to answer one of your questions, yeah, I think that we'll probably find that some of these larger inner bodies with some modularity of their stiffness will improve our capacity to hold the spine a little bit better. But there's still a great importance of acknowledging that the bone integrity and our mission to hold it together and get it to heal needs some metabolic support too. Recognition that we got to work it up ahead and be diligent beyond just the screws, rods, and cages.
Absolutely. Thank you so much for your time. I got to run, but if you guys have any questions, shoot me an email, please. Bob, thanks again. I really appreciate the invite.